Good afternoon. My name is Dr. Diane Barish, and we wanted to start with our Pennsylvania University Acknowledgement of Land. The Pennsylvania State University campuses are located on the original homelands of the Erie, Haudenosaunee, Lenape, Shawnee, Susquehannock, and Wazazi nations. As a land-grant institution, we acknowledge and honor the traditional caretakers of these lands and strive to understand and model their responsible stewardship. We also acknowledge the longer history of these lands and our place in their history. And welcome everyone, and thank you so much for joining us at our CGNE seminar series this afternoon. As I said, my name is Dr. Diane Barish, and it is my pleasure to serve as the host today for the CGNE seminar series. This program is being provided by the Tressa Neese and Helen Diskovich Center for Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Outreach and Professional Development Office, the Center for Nursing Research, and AgeFriendly Care PA. Today's seminar, Socio-Contextual Factors Related to Health and Well-Being in Diverse Older Communities, will be presented by Dr. Alyssa Gamaldo, Associate Professor of Human Development and Family Studies at the Penn State College of Health and Human Development. Before this informative session begins, we have a few disclosures and announcements to read. The Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, Zoom in and out times will be recorded, and the post-event evaluation survey must be completed. The seminar is being recorded. Questions will be addressed during the Q&A discussion portion of the seminar in the following ways. You can enter them into the chat feature, or you can also use the raise hand feature and you will be unmuted. The post-event evaluation survey link will be placed into the chat at the end of the presentation, and it will also be emailed to you within 24 hours. Just a reminder, the evaluation must be completed within 1 week of the seminar, especially if you are looking for those RN contact hours. It is required. However, we do ask that all attendees complete the post-event evaluation to assist with data collection related to our center activities and for Age-Friendly Care PA to help us improve our programming. The Nursing Continuing Professional Development certificates will be emailed to registered nurse participants who meet all the requirements within 1 month following the seminar. If you have any questions or comments, please don't hesitate to reach out to us at our email cgne@psu.edu. So next, I'd like to introduce our PhD student who is helping us today, Sharif Olanriaju. He is a CGNE, easy for me to say, graduate student affiliate. He is currently enrolled in our PhD program with a focus on internationally educated nurses caring for older adults. Thank you so much for introducing our speakers today, Sharif.
Thank you so much, Dr. Barish. I have the privilege this afternoon to introduce Dr. Alyssa Gamaldo, who is an associate professor of human development and family studies at the Pennsylvania State University. She had a PhD in long-span developmental psychology from North Carolina State University and completed a postdoctoral fellowship at the National Institute on Aging, NIA. She's an expert in aging and health disparities, particularly cognitive aging disparity. Her research focuses on identifying adverse like poor sleep, financial strain, and resource constraints, and protective factors, which include education, life satisfaction, and social support associated with physical and cognitive functioning, particularly in population at risk for Alzheimer's disease and other related dementia diagnoses such as Black adults. Join me this afternoon to welcome Dr. Alisa. Thank you.
Well, thank you so much, everyone. I hope you can hear me. But I wanted to thank you, Sheree, for that lovely introduction. And thank you to you all for this opportunity to meet with you this afternoon and share this topic that I am quite fascinated with. And I'm going to give you some examples from the work that myself and several of my collaborators, including some of my fantastic grad students, are working on to better understand how socio-contextual factors could be useful in helping us understand health and well-being, particularly in our very diverse and growingly diverse older adult communities. And just to let you all know, I actually am also, along with my associate professor status, I'm also serving as the co-director for the Community Engagement Research Corps for Penn State's Clinical Translational Science Institute, or CTSI for short. So I do want to also touch on some of the work that I'm partnered with in my role as co-director for this role, and how that also adds to hopefully this narrative that I'm going to explain to you today. So, according to the U.S. Census Bureau, is as of 2017, they released this information, and along with this information came this infographic to show that based on projections, demography projections, we are an aging U.S. nation, and for the first time in U.S. history, by 2034, it's anticipated that we will have more of an older adult population, 65 and older, than a young or child population, individuals under the age of 17. And so as you can see in this infogram, that is likely going to be increasing even beyond 2034. In fact, up until 2060, it's estimated that we'll probably have more than 500 million more older adults compared to children under the age of 18. So this is very significant, particularly in US history, because this actually signifies that the types of resources that we will need to help sustain health and quality of life for this growing new population that we've ever experienced here in the US is definitely going to be warranted and needed. And this is particularly true in the state that I am in, living in and working in, as well as some of you who are at Penn State. In the state of Pennsylvania, we are expecting to see, just like these projections, a surge in our aging community. In fact, we are one of these few states where it's expected by these projections, we will see even a greater surge in our older adult population. But along with this larger demographic surge that we're anticipating with older adult communities, we're also seeing some trends when we look within our racial and ethnic aging populations. In that we're expecting to see particularly a larger growth of our non-Hispanic, non-Hispanic Black, non-Hispanic Asian, as well as our Hispanic and other non-Hispanic other races in terms of population growth. And so according to this projection that was actually published around 2017, 2018 from the Federal Interagency on Age-Related Statistics, it's anticipated by 2060 that we'll see a drop from 2014, about 23% of our non-Hispanic older white adults, but we'll be expecting increases, roughly about 3% more of our non-Hispanic Black older adults, 5% of our non-Hispanic Asian older adults, maybe around 2% for other races not included in here, and then 14%, the largest percent increase will be expected for her Hispanic older adults. this demographic change that we're seeing, particularly as it pertains to racial and ethnic aging groups, is relevant given that there are several chronic conditions for those, as illustrated here, for adults 65 and older, where we're seeing disparities between our racial and ethnic groups compared to non-Hispanic whites in terms of many of these chronic conditions. And an example of this is illustrated in this infographic that was actually coming from the US Against Alzheimer's Disease, which shows that cardiovascular and metabolic conditions such as hypertension, stroke, diabetes, obesity are particularly high within our older African Americans as well as our older Latino populations. And for the work that I'm interested in, which is focusing on Alzheimer's disease, which is a common chronic condition that we're seeing in adults in general, and we're seeing a rise potentially in this as the demography of older adults increases. So as you can see in this infographic that actually comes from the Centers of Medicaid and Medicare Services, we're expecting an increase from 5 million in 2014 to anticipated 14 million cases of older adults that will be diagnosed with Alzheimer's disease. But we're also seeing potential disparities currently, and it's expected that these disparities will further remain the same, if not increase, as we're seeing a rising population of our older adults coming from these specific racial and ethnic groups. So based on these statistics, which were released in 2014, we were seeing roughly about 14% of our African Americans have been diagnosed with Alzheimer's disease or related dementia, and then 12% of Hispanics were also being diagnosed, much higher rates than our non-Hispanic whites, where the diagnosis was around 10%. And in fact, not illustrated here, the estimates have actually consistently shown that African Americans are 2 to 3 times more likely than other racial and ethnic groups to be diagnosed with Alzheimer's disease and or related dementia. So this is definitely where my work has really centered around, is really trying to make sense of how do we address some of these disparities that we're seeing, particularly for our older adults, as it pertains to disparities due to race and or socioeconomic status. And so one of the factors we tend to focus on is this idea of, we tend to look at the individual. And so and I am guilty of this, where we want to look at the interpersonal level and kind of look at what are people doing in terms of behaviors, their age, so those are socio-demographic factors, even like, their years of education and their knowledge skills. But we tend to forget that the person doesn't live in a vacuum. They actually are living in a context. And so we need to actually explore beyond just looking at the individual and looking at behaviors and emotions and mood. We need to actually look at these outer layers. And this is very similar to, if you're familiar with the Bronfenbrenner model, socio-ecological model, this actually incorporates that theory that, there is an intersection happening of how these different layers are impacting each other. And that could further explain why we're seeing these health outcomes for individuals, or risk for these health outcomes for some individuals and not others. It also further helps us to better understand and appreciate that there's heterogeneity happening amongst our diverse older adult population. And it's because of these different layers and how they're intersecting and interrelating with each other over time. So by incorporating this approach and recognizing that we really do need to pay more attention to these outer layers at the interpersonal, community, even at the macro level, that requires us to really think about these social contextual factors, which is the reason why I'm interested in looking at these factors as it relates to more at the individual level in terms of health. And by doing this actually can help set us up to recognize that it may not be one solution to address an individual's health and well-being. It's likely going to be a combination of different solutions that we might have to tap into one at a time or simultaneously. So thinking about how having this type of exploration could really facilitate putting more in our toolbox of potential programs and services we can offer to really better tailor health programs to our older adult communities. And so one of the areas that my team, and I'm going to share some examples of some of the work that we're doing, has focused on is really look at the neighborhood characteristics. And so the significance of why we're focusing on the neighborhood characteristics is because there's an increasing older adult population that's going to be demanding greater need for environments that are more age-friendly. And this actually gives you on the right, the infogram shows you that the amount of housing units is projected to more than double in terms of housing that's conducive for older adults. So by 2040, you're seeing probably 1 million plus more units are going to be needed to cater to our growing older adult population. And it's also important to keep in mind that many of our older adult populations are coming from low income households. So that's going to add to the complexity of the amount of housing projects that we need that are going to be they're going to have to be affordable for many of our older adult populations with a restricted income. So this idea of like creating these age-friendly communities is something that's been talked about. And I remember this was something talked about, particularly during the Obama administration, where they actually had several committees go out across the country and really kind of work with different aging researchers at different institutions to come up with a comprehensive plan of how do we create an environment, particularly in the US, conducive, knowing that the projections of our older adult population is increasing in the US. And through efforts like this, as well as global efforts that are also dealing with their own aging population growth, people have come up, particularly like the World Health Organization and even AARP, have come up with strategies to think about how do we create neighborhoods that are friendly to the health and social needs of our growing older adult populations, but also recognizing too that we've got a very diverse older adult population and making sure we're providing a number of different resources that are utilized and of interest to those different heterogeneous interests and needs. So the WHO organization actually was one of the first to really come up with this set of parameters of different domains of livability that could achieve potentially a really beneficial community for the older adult population. And some of the big domains that they identified that, you know, different planning members who are building new housing and new development should be thinking about is the ones listed here, which is inclusive of not just housing or open spaces in the neighborhood, like green spaces, like parks, or blue spaces like water, access to water, but also thinking about transportation and also activities that are convenient for older adults to engage in. ARP also launched a network to provide a toolkit that city planners could use to help them facilitate developing these communities that are more age-friendly. So while we have these efforts going on, and they've been going on for quite some time, they could be extremely advantageous for many of our older adults. But the fact of the matter is, these environments are not necessarily accessible or being experienced right now with our diverse older adult population. And until we recognize that this is the case and we monitor this, it's likely that this will remain the same if we don't really address some of this. And so for many of our older adults, as I mentioned, they're experiencing economic inequities. We're also dealing with older adults that have been socially marginalized throughout their life course through systematic discrimination or overt forms of discrimination. And that has trickled down into some of these social and economic inequities that we're seeing that could be related to housing quality, food insecurity, education insecurity, safety issues in their communities that they're in, and as well as access to healthcare and quality healthcare at that. So with that said, you know, with these disparities that we're seeing in terms of socioeconomics and the types of neighborhoods individuals are living in, it's likely that these will persist. And we're not going to see, for some of our older adult populations experiencing these inequities, that's going to have, creating these environments is necessarily going to be conducive. So what this says is maybe we need to pay attention to how neighborhood quality, as we're seeing it now, particularly for some of our older adult populations that are living in these less advantageous neighborhoods, how is it impacting their health and in what ways, so that it's better, we're better able to kind of target how do we modify those specific characteristics of their neighborhood. And so this brings me to the different types of neighborhood measurements that we typically are using to get at these types of questions. So one approach we could use is more of a direct approach. And this is like an approach that typically you could think of meeting a person one-on-one, like this individual you see on the screen, and specifically asking this individual subjectively, how do you perceive your environment, your neighborhood? So that could be based on physical attributes, like, do you see a lot of graffiti in your neighborhood? Do you see a lot of crime? Do you see a lot of like disorderly conduct in your neighborhood? So that would be an assessment of more of like neighborhood disorder perceptions. Another way we could also survey this individual about their experiences in the neighborhood is we could ask questions regarding the social quality of the neighborhood. So an example of this would be asking the individual, well, how cohesive do you find your neighbors are? Do you feel like your neighbors are willing to work together, have the same values, willing to help each other out when needed? So a great example of this, if you think about it, we're in Pennsylvania, so it snows here. A way that you can see cohesion is when it's snowing and you get a lot of snowfall, and then you see neighbors actually going out, especially with their older neighbors, and helping to shovel their sidewalks so their older neighbors don't have to shovel it themselves and potentially injure themselves. So that would be an example of social cohesion we might see amongst neighbors and the perception of the individual feeling that they have that cohesion. The other way we can assess from a subjective point of view is asking the individual, do you feel like you have easy access to resources in your neighborhood, whether it's social, whether it's health resources, whether it's economic resources like job opportunities? Do you have easy access to those things? Are you using those available resources in your community? Are they affordable? And affordability, I'll talk about leisure activities and constraint. Affordability can come from the form, yes, I have access to engage with my neighbors and my friends, but all of those activities are not really affordable. They're quite expensive. So affordability is also important in terms of this type of assessment. So that's one way I'm thinking about how we look at the type of neighborhood measures. The other type that we could look at is through a more indirect approach, where we're not really technically directly engaging with the individual and asking about how they feel. We're actually extrapolating some of this information from publicly available databases, like population databases such as the Census Bureau, the Department of Labor Statistics, Department of Education, and we're actually taking that data and aggregating that data to kind of get an idea of, from this data, what does the socioeconomics look like for the neighborhood? Like, how many people in the neighborhood are we seeing are having low reported income? How many businesses are we seeing within the neighborhood that this person resides? How many schools are in this neighborhood, or what the ranking of the schools are in those neighborhoods are some of the parameters that we can extrapolate. And more importantly, from a housing perspective, how many housing units are available for sale, and what is the price of those houses for sale? Can also be a meaningful metric that we could pull indirectly to get at the type of neighborhood a person might be living in, and how that could be advantageous or disadvantageous for the individual. The other way we can indirectly monitor, and this is actually becoming a even more promising way of detecting what people are experiencing in their neighborhood, is using monitoring systems. So actually, collecting samples of water quality, having individuals walk around with devices that they could pin to their clothing or strap onto a handbag or a bag that will actually measure air pollution quality. So with those types of monitoring systems, we can actually get at, what type of toxins are they being exposed to in terms of their water, their air, noise pollution. We could get at that, and we could see how that also impacts their health and well-being. Another popular one that we could think about that we're naturally walking around and getting on this type of monitoring system is your lovely cell phone, where we can actually kind of track people's steps. Now there's apps on here that can track people's moods, and we could also track people's sleep. And even your watches, even more so, we could get a better self-monitoring system where people may not even be consciously aware that they are getting tracked in terms of some of these things that they're being exposed to in their environment. So these are definitely some growing monitoring systems as technology is advancing and the devices using the technology is advancing of ways that we can indirectly test neighborhood measurements. So out of these two measurements, there's been research that's been conducted with both. And when you look at the research in general, there seems to be a lot of research that definitely focuses on the direct more approach. And there's actually a great systematic review that was published in 2019 by Young and colleagues that actually found that people's perception of their neighborhood problems was significantly associated with self-reported health, but the literature seemed to be mixed regarding perception of neighborhood problems as it relates to physical functioning or mental health. And actually, a more recent study by Quinn et al. In 2021, published in the Archives of Gerontology and Geriatrics, observed in over 7,000 participants from the National Health and Aging Trends Study, NHATS for short, that better perceived neighborhood social cohesion significantly predicted less limitations in activities of living, as well as instrumental activities of daily living over an 8-year period. But in contrast, a more perceived physical disorder in their environment predicted more instrumental activities of daily living over the same 8-year period. So we're getting a growing amount of literature that really talks about the self-reported aspect, but less has been done looking at these indirect methods of neighborhood and how that relates to health. So this brings me to my first example study I'd like to talk to you about, coming out from the collaborations that I have with several investigators internally here at Penn State, but also external to Penn State, working at different institutions. And so this study that I'm going to show you examples of us using these neighborhood quality metrics, particularly indirect ones, is going to focus strictly on this study called the Baltimore Study of Black Aging. And this is a study that actually was conducted roughly around 2005 up until 2009. 2 waves of data were collected in this study. So we were able to kind of look at people at 2 time points over a 3 to 4 year period. And I want to mention that the principal investigators of this study were Dr. Keith Whitfield, who is actually the president of UNLV, and Dr. Jason Allaire, who is actually a faculty member at North Carolina State University. This study was conducted as in name in Baltimore, Maryland. And this is actually this building here that you see here is actually one of the major housing complexes where participants were recruited from. And in fact, on the side of this building is actually where the offices were, where our research interviewers were positioned to engage with the older residents that were recruited and involved in the study. So the study aims, based on the data that was collected, was really focusing on neighborhood disadvantage as it relates to health. And I'll tell you in a moment how we measure each of these different constructs. But the participants actually included were Black older adults residing in independent housing. The age range was approximately 45 to 95 years of age. Most of our participants were female. And in terms of education, on average, people had at least a high school education, but we did have a range of people who had an education as low as like high school or like right around the end of middle school up until like having a postgraduate degree. In terms of measures, all the measures that we had were actually administered in buildings such as this, whether it would be in the participant's home, or if that was not suitable for the participant, it would be in a unoccupied like area of the building, whether it might be in the offices of where the staff were, or in a vacant library, or in a vacant room that was available for the interviewers to meet with the residents. And the specific measures that were administered by our field interviewers were sociodemographic measures that tapped into things such as education, like years of education, quality of education, income levels. Also, more importantly, getting at from the perspective of the individual, how well did their income meet their everyday needs? And so that metric actually gets more at financial strain, which is really actually a very unique and sensitive measure that really kind of captures how well does a person's income really address purchasing the things that are relevant and needful for them. The other things that we also measured were physical measures. So examples of some of the physical measures that were assessed were self-rated health. We asked participants about the number of health conditions that they had actually been diagnosed by their practitioner or nurse practitioner, as well as for some of the common health conditions that we see are highly prevalent in older African Americans, such as diabetes and hypertension. We further asked questions regarding whether or not the person was taking medications and how consistently were they taking their medications for these conditions. We also assessed levels of dependency in terms of physical functioning. And so we were able to look at physical functioning limitations and risk for mobility or disability. And then we also, our field interviewers, our research interviewers actually assessed blood pressure and heart rate, as well as pulmonary functioning using blood pressure devices for blood pressure and heart rate, and then a peak flow meter for the pulmonary function. Our research interviewers also administered some of the traditional psychometric or neuropsych cognitive tests to kind of get at not only global mental status, but also specifically to get an idea of how the person was performing on specific cognitive abilities, such as memory, processing speed, visual spatial functioning, language, and whatnot. So in terms of ADI, what we actually measured, we used a metric that was actually created out of University of Wisconsin. And the person who's overseeing this effort of creating this area deprivation index and sharing this index across the country to anybody who wants to access this information is Dr. Amy Kine. And so this is actually an index based on publicly available data of socioeconomic factors within a particular geographic location. And so this information is actually really identified at a census block level. And so based on this data, they're able to kind of assess, like the socioeconomics in terms of the income in that block level, the education levels, the employment levels, and the housing quality levels. And this data is actually readily available. You can actually sign up and you can actually download this data right now. Currently, they have online, if you actually register to be a part of accessing the data, you can actually get data from 2015 and 2018 regarding this metric that's, like I said, getting at the socioeconomics of the neighborhood. The data is actually uploaded every 5 years or so in terms of why you see it's for 2015 and 2018. And so what's nice about this data is you can kind of get two metrics. You could get what's called the state IDI, and this actually gives you an idea of the level of neighborhood disadvantage compared to other census block or neighborhoods within the particular state you're looking in. So this illustration you see on my screen is an example of the ADI map that's available on this website, by the way, for the state of Maryland, which is the state where our participants from the Baltimore Study of Black Aging were recruited from. And so if you go on the website and you scroll over this, it will actually pop up where you put your cursor, what that particular block has in terms of the state ADI. And that ADI score is representing how much in terms of a scale of in terms of 1 to 10, where 1 means least disadvantageous and 10 means more disadvantageous, is that particular geographic location compared to the rest of the state. They also have a metric called national ADI. And so this one is more on a broader level in terms of looking at neighborhood disadvantage. So for here, you're actually getting a comparison of, given your block, group, or neighborhood, how does your neighborhood compare in terms of advantageous resources versus disadvantageous resources compared to the rest of the US. And this scale actually goes from 1 to now 100, where 1 represents more advantageous resources versus 100 means more disadvantageous resources. So we took both of these index and we actually worked with Dr. Kine because given the time frame our data was collected and talking to her about what would be the appropriate ADI data to extrapolate in terms of time, we were able to ask and get from her group ADI index from 2010, which closer fits the time period of when we collected the data. And with those ADI indexes at the state and national level, we were able to look at the risk for health outcomes as it relates to this ADI score. I just want to point out that what we were doing was validated by empirical evidence that had also observed that looking at these ADI scores as it relates to health seemed to show a signal in that prior research had shown that ADI was associated with risk for health outcomes such as diabetes and cardiovascular risk, as well as health utilization and mortality. So my student spearheaded the way once we had the data to actually look at this data, and I'm happy to say she was able to publish on the data that I'm about to show you in the Journals of Gerontology, Society, Psychological Sciences. And so be on the lookout. It's in press right now, but it should soon be available online. And what she did initially was look at the cross-sectional data, particularly wave 1 of the SBA, to look at the question of whether or not ADI was associated with different physical health outcomes, whether they're subjective or objective. And so here in this table on the right, what she actually saw, and this is just a sum up of the significant associations as highlighted by the green checkoff, is that the national ADI ranking seemed to be significantly associated with our older African-American sample with their self-rated health, whereas the state ADI ranking was associated with activities of daily living in the sample. For all the other subjective parameters, or even our objective parameters with systolic blood pressure, diastolic blood pressure, even some of the cardiovascular risk factors that they were diagnosed with, which is including diabetes, hypertension, risk for stroke, ADI did not seem to be significantly associated with any of those parameters cross-sectional. So when we looked at the directionality of these associations, what we did find is a main effect showing that better self-rated health was actually associated with living in a more disadvantageous neighborhood based on that national rank. And this was in models that actually adjusted for demographic as well as socioeconomic covariates. And we also saw a very interesting interaction, particularly with age. So this relationship seemed to be particularly evident in older adults 65 years of age or older. In this cross-sectional analysis, we also observed that less difficulty with ADLs was associated with living in a more disadvantageous neighborhood based on the state ADI rank. So I'm going to pause here. Some of you may be thinking, okay, it's counterintuitive. One would have thought better self-health, living in a more disadvantageous, wouldn't it be the reverse? And same applies even for ADLs, like less difficulty living in a more disadvantageous neighborhood. That's the same thing that we, as my collaborators, including my grad student who led this, Alexa, we all had that same pause. So how do we make sense of this? Well, one, I just want to point out the idea that looking at these different types of ranking, whether at the state and national level, is important, because as you could see, the associations that we're seeing across our different health parameters varies depending on which of our ADI metrics we're using. And it seems to make logical sense why this is, because looking at the state of Maryland, if you actually look at the state of Maryland in terms of some of these socioeconomic profiles compared to the rest of the nation, the state of Maryland looks pretty good on average, right? So like that may be biased in and of itself, but when you look in the state of Maryland, you don't see the same socioeconomic profiles across the state. And that's the problem when you aggregate at the state level and do the comparison. When you look within the state, we're seeing that some blocks are experiencing more disadvantageous socioeconomic conditions than other blocks in the same state. And so it's really important to like think about these metrics may not be giving us the same information in terms of how they relate to health outcome. So that's one thing that I think was interesting about these findings, is that that kind of supported that idea. But to go to this counterintuitive finding in terms of directionality, we actually, were thinking, well, perhaps, this ADI metric is limited in capturing the social resources. Because remember, as I mentioned, ADI is capturing socioeconomic parameters, right? In terms of like that publicly available data that I told you they're utilizing. And so by us not capturing like potential social resources, these social resources may be actually protecting people's health despite the adverse socioeconomic conditions of their neighborhood. And so that pushed us to look at this further, but also think about, okay, we're looking at this at one time point, right? What does this association look like over time, right? And more importantly, if we incorporated these social resources, then we better be able to understand patterns like something like what we're seeing here, or maybe we'll be getting a better idea of what may be going on to kind of explain some of these findings that seem counterintuitive in terms of directionality. So Alexa has since pushed forward and trying to like further like disentangle what's going on here. And this was actually some preliminary data that she's actually got a paper in progress to write up and submit. This was information she presented at the recent Gerontology Society of America conference in 2022. And in this case, we actually merged together both waves of the Baltimore study of Black aging in terms of those various health parameters. And we created a change score for each of those health parameters so that we could look at 2 to 3 year changes of those health parameters as it relates to the area deprivation index. And as a result of this approach, what she observed was that now we're seeing that indeed significant increases in heart rate over two to 3 years was actually related to ADI. And that's particularly true for this model here, as you can see, based on national ranking. So this is actually suggesting that participants with increasing heart rate were living in less disadvantageous neighborhoods compared to the rest of the nation. And then it's also illustrated to this finding for the state ADI ranking. And so interpretation of that would be participants with increasing heart rate were living in, again, less disadvantageous neighborhoods compared to other neighborhoods within the state of Maryland. She also saw some interactions with the social support, both at the national ADI rank level and also the state ADI rank level. And so I'll show you what those interactions look like in a figure in a moment, but I also want to show you that we saw a similar type of pattern with ADLs. So with increasing difficulties with ADLs over the 2 to 3 years, we saw a significant association with ADI, and we saw that at the national rank level after adjusting for covariates. And what we saw was participants reporting increasing levels with ADLs were living in a neighborhood with greater disadvantaged. And we particularly saw it also at the state rank level. So again, participants reporting increasing difficulties with ADL over the 2 to 3 period were also living in more greater disadvantaged neighborhoods. So this seemed to be going in the direction as one would anticipate. But again, what we were seeing with the heart rate was further supporting the unusual finding that we saw with the cross-sectional work. So when we actually looked at that interaction that we saw with social support and increasing heart rate in both the national and state ADI, this illustration shows you what we're seeing with the national ADI ranking as it relates to health rate, but varying by social support. So what this figure actually shows you, if you look at the dotted green line, that represents people who are reporting more social support received. And so for particularly those individuals, we were seeing that increasing heart rate over the 2 to 3 year period was associated with living in a less disadvantageous neighborhood in comparison to people receiving less social support received. And so that was something that we saw here. And we saw a similar consistent pattern for the state ADI rank. So again, individuals who are reporting more social support received were more inclined to report increasing heart rates 2 to 3 years later, the more they were reporting living in a less disadvantageous neighborhood. So I'm going to pause right here. What's going on there? Like, what's explaining that? Well, you know, interestingly, the literature actually is not far off supporting what we're observing here in terms of these patterns. In fact, there was a study by Mosevitz in 2013 that also looked in a longitudinal study of predominantly African Americans, and they also observed that social support received appeared to buffer disassociation between stress and self-rated, particularly for individuals at risk for living in disadvantageous neighborhoods. And that kind of fits what you're seeing towards this pattern here. For those who are in the less advantageous neighborhood at the state and even at the national level, if I look back, they're actually reporting less increases in heart rate over time, the more they're reporting social support received. And so this may signify a message that's actually coming from a paper that was published by Bird and colleagues using the same BSA data set in 2021, where they also looked at social support received and as that relates to high blood pressure, in that, you know, there's different forms of social support. I mean, we're just looking at social support received here. And to clarify what received is this is a question that you're asking people, okay, how much support are you getting financially, emotionally, and whatnot from the people around you? And what the Bird study actually said that this form of social support is not the only one. There are other forms of social support, like social support given, perceived amount of social support resources you have available, and whatnot. And those different types of social support could maybe differentially impact a person's health outcomes, and also it could vary based on the socioeconomic or sociodemographic factors available to that person. So it makes me think about, it's not just to think about, there are so many different metrics of social support that we could further dive into to really kind of make sense of these patterns, is to really think forward in terms of that the networks, but also the quality of networks that might be available for people, particularly in these different neighborhood characteristics. So for one, we might be in the types and quality of those social networks for some of our participants living in this disadvantageous neighborhoods may look very different than the type of social networks and the quality of those networks for our participants living in less disadvantageous neighborhoods. And that, for that reason, that's why we might be seeing these differential health. So I know that, you know, again, this is just a thought. Again, more research needs to be done to really kind of see if we have empirical evidence to support what I just described, but it just further explains that there's something to be said about these metrics, but also something to be said about the complexity of these interrelationships that we're observing. The other thing that we looked at with ADI in this same study is looking at how it relates to cognition. And we looked at this cross-sectionally first. And we actually observed that for individuals living in less disadvantageous neighborhood, they tended to have better performance on measures of immediate memory, vocabulary, reasoning, and everyday functioning. And that seems to be in the direction that many of us would anticipate. But we also saw a mixed actual finding in terms of, for our individuals living in more disadvantageous neighborhood, we saw better performance for them in terms of attention and working memory. When we looked at this longitudinally, we also found that, people living in more disadvantageous neighborhoods, while they declined on certain cognitive abilities such as global mental status over the 2 to 3 year period, as well as visual spatial functioning, we also saw improvements in terms of certain cognitive abilities. And those improvements we saw for individuals in these disadvantageous neighborhoods appear to be for memory and working memory. And so again, it illustrates the mixed patterns that we also saw with our physical health outcomes as it relates to ADI. So to kind of conclude what this all said potentially is reflecting is that there are important advantages to living in a better neighborhood. And that's reflected in terms of the cognitive findings I'm showing you. But for those individuals living in our disadvantaged neighborhoods, there could be some sort of resiliency or proxies of resiliency that seem to be protective, despite that they're living in these maybe what from our point, an adverse context. And that could be the reason why we're still seeing those individuals on some of our health outcomes are not showing that they're doing worse. They may be showing that they're doing just as good, or in some cases, maybe even better. And so that's something to point out and something further that needs to be investigated. But despite these mixed findings and these complexities that, I am wrapping my head around, and hopefully some of you may be feeling the same way, there's something to be said about something meaningful is coming out from these metrics of neighborhood context. And there could be some unique information about intricacies in terms of these interrelationships that we're seeing from a contextual level and how it impacts the individual levels of health and cognition, particularly for our diverse older adult populations. And particularly in this case, for our heterogeneous population of African Americans. And I want to put that out very clearly because there's actually literature, and it's actually coming from a paper from Dr. Keith Whitfield. You should definitely look it up, talking about within-person exploration, particularly within a racial group versus cross-racial comparisons. And the fact that his work has actually shown, and in this paper, he brings this messaging, that there's so much heterogeneity when we look within our certain racial and ethnic groups, particularly African Americans, that when we look at that within the groups, we can really appreciate the heterogeneity that we will see in terms of social experiences, in terms of health outcomes, in terms of well-being. That it's meaningful to really sit down and take a look at all of that variability that you see within the race, that if you're doing the cross-racial comparisons, you may be masking some of that unique heterogeneous experiences of that group. So I'm going to switch gears and talk about beyond just the neighborhood. Let's talk about how the resources of the neighborhood, and this is where leisure engagement comes in terms of how that could impact people's health. And how this is also a promising topic that I think requires further exploration. And there's people in the field who are already doing this fantastic work. And I still think there's great opportunities for us to even advance this work, because I do think it's truly meaningful, particularly with our rising older adult population. So why is this significant? Leisure engagement actually signifies activities that older adults are likely to select given their time available to them. And so this gives you a picture of all the potential, and this is not exhaustive, but some examples of the types of leisure activities that we are likely to see people engage in, or even our older adults. we see that approximately our older adults are engaging in about 7 to 7.1 hours per day in leisure activities. And with advancing age, people's engagement in some of these activities will likely transition from more physically active activities to more passive activities, such as watching television. In fact, much of the leisure activity engagement that we see older adults engaging in is watching television or doing some type of entertainment resource, roughly about 5 to 7 hours per day, which is considered a passive or sedentary leisure activity. We don't want to see this trend because what we do know is that when we see older adults engaging in more cognitively stimulating, physically stimulating, and social activities, they actually show better psychosocial well-being and health. And that's in terms of physical, cognitive, and mental health.
Dr. Gamaldo?
Sorry.
I'm so sorry to interrupt, but I just wanted to point out we are coming up at the end of our time.
Oh, I'm sorry.
I'm so very sorry. But I just wanted to give an opportunity if you had any sort of final thoughts, if you just wanted to take a couple of minutes. Jenny Rank also put the link for our evaluation survey in the chat. If folks want to take a second to fill those out, that would be great. And I don't know if we're going to have any time for Q&A, maybe just 1 or 2 quick questions. But Dr. Gamaldo, did you just have anything you wanted to wrap up with?
Yeah. So I guess let me skip through. But one of the things I wanted to say is that, leisure engagement is something definitely we could be observing is also changing on a daily basis for people, especially our older adults, and recognizing that it's not something that's static that is going to be consistent over time. It's something that we see fluctuating. And the fluctuation of those engagement in those activities on a daily basis could be due to how people are feeling, whether physically, emotionally, and that could be meaningful in terms of whether or not we need to help that person gather resources to help them to be consistent in those behaviors. The other thing I just want to follow up on, and I'm sorry I didn't get a chance to show, I was so excited to show you this work, is really kind of looking at the intersection of like transportation. And this is my grad student, Joanne, who's done this fantastic work looking at modes of transportation access and how that relates to leisure constraints. And in this population of lower socioeconomic older adults, we found that most of them are reporting that they're having others or relying on others to transport them. And that could actually have an impact on actually their leisure, perceived leisure constraints. The other thing that I want to point out just to end up is that, we need to think about evaluation in terms of our different approaches. So we've done the laboratory, but with COVID, we've actually had to transition from our in-person approaches to more of these telehealth or digital health approaches, but there's pros and cons to each of these. And especially for many of our older adults who are looking for more social engagement, and it really impacted them during COVID, really thinking about how we don't want to necessarily go in one direction and push for one direction, like the telehealth and digital health. Many of our older adults would like the in-person still, and to maintain that engagement. And then one thing I want to point out is that you all at the School of Nursing have been really prominent in terms of pushing this other initiative that I believe strongly in, which is the Community Resource Fair. And that's actually going into facilities for older adults, like affordable housing complexes for older adults, and coming in there as a group, providing many different resources for older adults, whether it's health, whether it's social services, but also providing training opportunities for our students who are training for different health services that will be likely working with older adults. So School of Nursing was actually a great participant in this community resource fair that I conducted in State College. And it's also another thing that we could think about of a way of getting at a wider audience of older adults in terms of providing services. And just think about this idea of we want to realize one size does not fit all in any of these approaches of how we evaluate or monitor or provide services. We really need to be thinking about the fact that we need to tailor these things to the individual, which means we need to collect more of the socioeconomic or contextual information along with the individual indicators to really kind of better tailor how we are providing services for people. And so I just want to leave on a final note, our older adults are definitely engaged and they are giving back to the community. but we need to be looking at what ways can we maintain their participation in our communities, because their impact is definitely helping the broader array of our community in terms of thriving. And so I just want to be clear that I can't do this alone. Teamwork makes the research work. And so these are all the collaborative teams, and this is not the exhaustive list, but I do appreciate the work that we've all put together to be able to show to you today. Last thing is I am doing a community outreach. So I'm going to leave this flyer up. This is an event that's affiliated with the CTSI, where we are actually collecting food and necessities to deliver to a community in Northern Dauphin County, who actually said that many of their community members are in need of these items. And so we would like to be able to provide them with these items. So if you are interested in providing food, clothing, toiletries, or paper, please feel free to drop off these items to HHD 237. So thank you. And I apologize for running over.
Thank you so much. Thank you so much. I know there's so much good information, and when you talk about the intersectionality of community with the aging experience for older adults, I mean, there's just so much to cover. I know it's such a rich topic area. When I was in graduate school at Miami of Ohio, they were actually working towards their age-friendly certification. The city of Oxford, where the school is located, the AARP age certification, and we were a part of that, doing like a community survey. So yes, it was a huge survey asking all kinds of questions about housing and walkability and transportation and availability of services. So yes, it's just such a rich topic area. And we really thank you so much for presenting today. And if anyone has any questions, you can feel free to send that to the CGNE or to Dr. Gamaldo, and I'm sure we can follow up with you after the fact. And just a quick reminder to please fill out the post-evaluation survey, especially if you are an RN looking for those contact hours that is required for those contact hours to be awarded. Thank you all so very much for joining us for our CGNE seminar series today. And we hope everybody has a great afternoon. Thank you so much.